Just a second. I need to.
Okay, I just started the recording.
Okay.
So we can go on with the seminar. And Outi, you can continue what you started to introduce yourself and go
Yes.
on with your presentation.
And you can see my slides, I assume.
Yes.
Okay. So I'm currently working as a chief physician or medical director of the Finnish Institute for Health and Welfare, and I'm in response of this mental health policy strategy implementation in Finland. And you will see that from my presentation. So we have a mental health policy for improving mental health, meaning positive mental health, prevention, and then the healthcare reform is currently providing me lots of work. But that's my background. I'm also a professor of psychiatry at McGill University in Canada. I lived there for 6 years previously. And to start with, I want to define what's meant by mental health in our view of the healthcare. So we want to stress the fact in the strategy that we have a dimensional thing called mental health disorder and no mental health disorder. And I know you must all be really well aware of the fact that that's not all. So we also have something called positive mental health, which you can have more or less. And then this is why we need mental health services, care and social services, people who have a mental health disorder, and they also have low level of positive mental health. So you kind of need both to a certain extent to be in need of treatment. But then sometimes you can have a mental health disorder, but it's in a stable phase, and you have a stable medication. You have you don't need acutely any mental health care. Instead, you might benefit from peer support, hobbies, self-management, individual placement, and support to increase your positive mental health, right? Or maintain your positive mental health. So you don't have to remain in a mental health care system in this phase of the illness. Now I need to get rid of these black boxes. It says, since you're recording it, I think it's that's why I have the, no. Anyways, I don't know what to do with this. But then you can also have lack of positive mental health, where you might benefit from peers, hobbies, school, some kind of support. You could benefit from support from the workplace, resilience increasing programs at the workplace, or some services from the third sector. And I think this is essential to understand. When we speak about mental health services, we don't only speak about psychiatric hospitals or clinics. There's so much more to that. Now I realize I can't. Okay. So I start from the positive mental health, and especially now that we have the pandemic, I think this is really crucial to understand. The pandemic and the way we handle the infections, it has caused a severe lack of positive mental health. And what I mean by that, we have reduced our activities, physical activities, sport, meeting our friends, doing sports. Personal relationships are digital. It's not as satisfying as in-person meetings, and so on. And I would state that, especially for young people, this has been really, really much more important than an actual need for mental health services as we traditionally see them, clinic, psychiatric clinic, and so on. And then I also want to say that we know that there are several levels of promoting positive mental health, how to get out from this pandemic. You need to see that there's the individual level. We can promote healthy lifestyles, we can increase physical exercise, improve self-esteem, and so on. We can bring young people back to social interaction, and it doesn't have to be anything with the medical system as such. But then there's a lot to do at the community level and at the structural level. And from previous severe infections, pandemics, we know that these are essential to get out from the pandemic. So I come from Finland. I'm presenting you the Finnish mental health care system. It's easy for me to smile here. We have a welfare state. We basically have the country built based on these this knowledge. We know we need all this to promote positive mental health. It's nice. It's not perfect, but it's an essential factor of working on this area in Finland. It's also my reason for coming back to Finland. One of the main reasons I saw that in Canada, I don't see the same governance of promoting factors and supportive factors I need as a psychiatrist. So it's really, really interesting. So, and then here are some factors you can do to promote positive mental health. And I think my audience today would be interested to see balancing physical, social, emotional, and mental health. And as I said, this is one of the essential pieces of interventions now to help people. So how we do that in Finland, we have some tools and really strategic methods of implementing these tools to schools. This is one picture from a package made for schools where they, for every grade, have a certain academic calendar, a piece of like for this month, how you can work towards better mental well-being. So children, even when they are really small, they learn interaction with peers. Here they are taught a method to set goals and to ask, so what would, this is 6th grade, so they are, I think, 13-year-old kids. So they should plan their goal, then they ask, so what should I do to reach this goal? Who could help me in reaching this? What's preventing me, and what should change so that I can actually reach the goal? So really nice images, pictures, and basically most schools in Finland would already use this academic calendar and these tools to work systematically towards, from year to year, based on an annual plan towards increasing well-being. We also collect systematically data on health promotion, including positive mental health. There's a survey. We have enormous amounts of data. We just received the results from the last survey, and really doesn't look good. And that's how we also know in a systematically evaluated way that decrease in the positive mental health was an essential factor to target at this stage. So then from to the next step, prevention of problems. So we have problems in mental health, substance abuse, suicides, and then we are in the early phase of detecting a risk, speaking about the risk and doing something. That's still not within the healthcare system itself. It could be done at school, at a workplace, elders' home. I took here some examples of projects and validated methods for mental health promotion, risk reducing methods from Finland. And I will not go into detail in all of them, but you can see that these are all like nationally implemented already. So we do have something for behavioral problems. It has been done for 10 years now. There's a systematic follow-up system built to know who was trained, who was met, what was the efficacy, how did the teachers and so on feel about this training. And this was not planned in Finland, but it's really well and systematically implemented in here. I will tell more about ice huts because I know it's based on sports and you would like it if you don't know it already. Then we have cool kits for anxiety, IPC. These are more towards treating, like therapeutic interventions. And then a few for like crime prevention or kids who have faced violence. So we do have for kids and adolescents, we do have really nice examples. For adults, not that much. But more for ice huts, this received a nice European prize award recently, and I think it's getting more and more famous. So they use team sports. They want to identify kids or adolescents who have some need for support, and they provide this support through doing sports together. So they basically combine what we could call social work, but it's not called a social worker. It's somebody who's bringing those kids to play football and so on. And the idea is to prevent social exclusion, enhance social skills, and promote well-being of these vulnerable children. Of course, they are not told they are vulnerable. They just they kind of have a hobby, and they are selected based on like in cooperation with the school, social services, and the parents, of course, need to agree on this program. And they have shown valid results from, so they can do what they want to do, and they do it well. So they have nice pages even in English. You will find it online. And if you like, I can put you in contact with those people who do this ice huts. They work in the same institute. Then another example, we have Anchor Work. They also have an English front page. So this is also promotion of well-being, but they focus on at risk for crimes or like extremism. And it's also widely used, well functioning as a model. And these are mainly, it's not within this public healthcare system that these are done. They operate outside this official system, and it's the third sector, and so separate projects, separate funding, not within the healthcare. And I think that's essential as an to work well for this. But despite the fact that they are outside the public healthcare system, they have a strong network and tools to keep it together and to maintain the knowledge and skills. Then a few sites, if you like, we have a systematic review of mental health care, preventive and somewhat towards treatment for kids, and they have like the level of evidence for validity of those methods. They often are focused on some lifestyle factors like sports, and then you have like no evidence or no data, but initial evidence, grade-wise classification of the methods and links to the materials. So that's also something you find in English. They also have a book about implementation theory, practical implementation theory, and I think that could also be in English, but not sure about that. This report is nice. They have a systematic review of early phase interventions. And then we have this digital self-management portal, which has been developed over maybe 10 years. The idea is that in public healthcare, the service providers would tell people to go there, or they go together. There are videos in YouTube, how to learn, relax, control your breathing, use that to sleep better. There are, like, you could call sleep interventions or stress interventions, controlling your emotions. So short courses online where you can use self-management and improve your well-being. We do have results from this kind of strategic work. So this is the curve for suicides. Long time ago, Finland was really sadly famous for the highest suicide number in the world, I think at this peak. And already luckily before the highest peak, there was a suicide prevention project. And it took 4 years to see a steep decrease in the number of suicides. Despite the pandemic, I can already tell 21, it's decreasing. So this is worldwide a rare example of systematic strategic work towards decreasing something through prevention. And now we are mid-level in Europe. Young people have a higher suicide rate, and now I'm among those people who now work focusing on the specific populations or areas where you have the highest risk. We certainly have to work with men and find new ways of reducing the suicide risk among men. And we specifically need to target drug-using adolescents to reduce the mortality in this population. But there's lots of knowledge about what worked well, what made this possible. And then I finally come to the mental health services. So we do have these services providing guidance, also self-management, advice, needs-based psychosocial support, which is not the same thing as psychotherapy. Lots of this psychosocial support in crisis situations is done by associations, patient associations, or families, peer support for families or patients, chat lines based on this. So outside the public healthcare sector again. And then, of course, the public sector would focus on the severe mental illness, a disorder where you need some medical treatments and rehabilitation. So the greatest volume absolutely is in the primary care. And what we have in Finland, we have healthcare centers, which are, they have been built all over, and a little bit too much when we now think. But the idea was that basically every village should have their doctor. And as this huge country as compared to the number of people, and especially doctors, that didn't quite work out. But we still have this. So we don't have family doctors, but we have primary care in healthcare centers where we actually have the service of doctors, nurses, social workers, child support, and more and more social services are also, and family services are all in one place, so that if the family has different kinds of problems, they wouldn't need to go to several places. And then we have specialist medical care facilities, which are centralized, of course. So then I mentioned already this NGO, the third sector importance of that. And notably, when we had the pandemic, we were completely dependent on the third sector providing crisis services, helplines in several languages for minorities, for people who don't go outside Discord. So finding novel technological innovations and really rapidly providing those services, which was really good. And the third sector is also essential in rehabilitation. So they have day programs, they have places to work or help others. Peer support is organized by the third sector, and that has been so for a long time. We have a strong private sector in Finland. It's not so much overlapping with the public sector in mental health. It's mostly pretty healthy people who work, and then they go to private sector. They pay, and the state would cover a certain amount of how to say, not realistic price. So you need to be working and have that money to go to the private sector. However, you can find psychiatrists, psychotherapists mostly work in the private sector. I mean, the public sector is trying to train psychotherapists and then they go to private. But it's still essential in this whole system to have the private sector. Based on the statistics, we know that most people have outpatient care. It's more and more. Actually, when I started 92 as in psychiatry, Italy was mentioned as the center for family psychotherapy, and that was this ideology and against psychiatric hospitals. I remember Italy from that story, and of course we have done the same in Finland. And the drop in the number of psychiatric beds it's enormous, and it has been too high. I think even globally that's but it's truly a problem in Finland currently. And I can show that as a curve here. So of course the number of outpatients has increased, and now I speak about people who are like individuals. So somehow there's a stable increase in the demand for services even before the pandemic, and I can tell you it's like exploding due to the pandemic. And then how we treat these people in outpatient care. We have this triangle model for primary care. So we train nurses for short interventions. We have a primary care physician help them, and then they should have a named a stable, always there consulting psychiatrist. And we have tested different models of this, and it doesn't work if you only have a psychiatric nurse here without these two other people supporting. It also doesn't work if you have these two, so you need the three of them. And this is something we are currently integrating more and more in several aspects to the healthcare centers. And then we have a specialized psychiatric care. It's mainly like we would say a city might have their services, and then we have 5 clinics in the whole country for tertiary specialized services. And like gender identity, we only have 2 clinics where we conduct those evaluations. And the biggest news for you today is the healthcare health and social services reform, which is huge. It's the biggest in history in Finland. I actually found a news link if you are interested to reading more. But we changed everything. We changed the structure. We work hard with the integration of services and the format of working with people. It's becoming more and more patient oriented and so on. And this is mandatory. This is like really Soviet Union style currently. And it's also mainly done because we had a community municipalities-based system, and what the state government has learned, they can't tell them anything. So they give money for mental health services and they use it for like anything. So now they want to force the healthcare into 21 counties, and the money comes from the government, so we can increase the options of guiding how they use the money and have indicators to show that they do what they are supposed to do in terms of efficacy. And mental health actually is the main reason for this reform. And the final slide, we also have national follow-up instruments. We do have them, but we need to work to improve them. But that's one of my tasks. We do have digital medical files. They can be combined. We can collect the data from all the country about what was done based on certain codes. We can measure efficacy in a few years about impact on mental health. But this is also lots of people working on this. Thank you. I'm happy to respond to your comments now, and then I also added my email so you can contact me later.
Tuti, really interesting. Are there any questions? Anyone has questions? I have one question regarding the strategy to tackle the suicides in Finland. How does it work? What was the strategy? You mentioned it, the identification of specific targets, and then what were the activities implemented with the target groups, and were they individual or more generic? There was like a direct contact with the potential person in danger, or it was a community activity?
No, they decided to do everything they could. So they knew that they need to work. So at individual level, they needed to confirm that the professionals recognize that when people are at risk. So they trained lots of professionals, like enormous amounts of training sessions. How do you recognize people are depressed? What are the risk factors for suicide? Substance abuse, you can't send people out. They need to be treated properly, and so on. So training professionals, then government. You need to prevent, like planning the bridges. They have regulations telling that a new bridge has to be planned in a way that we know it's safe for suicide. Or railway stations, there are certain regulations. So methods of suicide, that was one way of prevention. Campaigns, like telling people, if you feel bad, there are people helping you. And so they did practically anything they could think of. And of course, then you don't know what was the best way, but we certainly know that, especially as an example, the regulations are important. You need systematically to evaluate, like city planning. You need to take into account the impact on suicides. We see the same. I know in Canada they have the same. It's not systematic in Canada, so you can see the cities where they have this in their planning, they have reduced suicides, and those who didn't, they have a higher number. There's no decrease.
Thanks. And another question regarding the first activities you described, the first initiatives. Are they funded by the Finnish government, or do they receive different funding from different actors, like private and public actors, like Ice Arts? I don't remember the name, the list. Are they all public initiatives funded by the Finnish government? Because in one of the last slides, with the reform, you wrote that the national, with the delegation to the counties, to the Finnish counties, then the government might guide and fund the mental health services. But before the reform, what was the policy to do?
Yes, so it's that previously it was it's collected in the tax. So the money for the services, it's collected in the tax, or preventive procedures within a city, as an example, it's collected in the tax. And now it's going to be the governmental tax, and then it's better in the governance of the government. But currently the government has, for mental health services, just for mental health services, the government has invested, I think, more than 100 million euro this year only. So they give enormous amounts of money as compared to the budget for mental health. So we have lots of money from the government. I think it's historically the highest ever. Then we do have a really, I'm almost ashamed of telling this, but we have a monopoly for games, digital games and so on. And the government always collected money from that. And this was given for this associations and organizations outside the public sector. And that's, I'm sure that for EASMH, as an example, this money was really essential. Now we have to close this funding because it's unethical. But this is something they now need to find another source of funding. But of course, then there's private funding as well, like other sources of funding and research projects.
Thanks.
So I wanted to ask you, thank you very much for your presentation. It has been very, very interesting for me. So the question, because we are, of course, we're trying to focus now on sports and how we can implement sports into rehabilitation, into psychiatric rehabilitation. So what would you say, how much does sport count in terms of rehabilitation? If you were to say, which percentage of activities, of rehabilitative activities are conducted through sport in Finland, what would be your estimate?
I can't tell you any numbers, but
even rough.
To start with, what's the easiest to respond is that in moderate depression, if you are depressed, sports, physical activity is equal in efficacy to medication. Like that's evidence-based treatment. And you know that you have a depressive episode, you have mild depression, you have moderate, and only in severe, you still say you need to increase physical exercise, but then you need medication and psychotherapy for sure. But it's really strong evidence for sports being efficient for your mental health. And of course, as a preventive factor, I don't have any data for you, but my statement is really that in this pandemic, the fact that people didn't move, they stayed home, they didn't have social interaction, that's really the fact that we need to change more than increasing psychiatric services. And like schools, I think that's what we see in Finland as essential. If you have a mental health problem, and what you need to do is at school or workplaces, there's lots to do with this common language, the way of thinking, and just organizing the money to go for mental health reasons to provide hobbies for kids. It's not that easy. It's different. People think of, like, the government would think mental health problem, healthcare funding. So that's one. And for the rehabilitation, I think that's the other way. That's where we have a stable system for a long time. It's the third sector. Like they always were felt to be important in rehabilitation. If you have schizophrenia, you have a weekly contact for several associations or other services from the third sector.
And would you say that there is a good connection between, for example, within the third sector, between sport facilities and people that are in charge of rehabilitation? How strong is this connection?
Well, it depends, but I know that there are several places where it's that they know that this time, like playing hockey, this time slot belongs to this third sector for psychiatric rehabilitation, and they have their team there. The next one, EASMH, so it's integrated because it's the city organization. They can plan it and they can say, and this is free skating, right?
Mm-hmm. Yes. So would you say there is a need to improve this scheme, or do you think it's already working sufficiently, or is there room for improvement?
There's room for improvement, but we do have a strong structure. I know that has been established already. We call it welfare network. So it's professionals and third sector and different service providers locally, and then nationally networking so that they can integrate all services.
Would you compare your system to UK, for example? You are familiar with I don't know if John is here. Yeah, he is. So, for example, they have these charities that are very strong, and they organize a lot of sports and would you compare Finland to UK in this sense?
It's completely different. Yeah, that's okay. Also in Canada. You see that we have an identity of having a welfare state, and often what you hear is, let's say there was a child hospital and they wanted to have funding through charity, so people were upset. They said, if you give money, it will collapse the idea of the welfare state. And they really like that. I had friends who were angry at me because I gave money. I am destroying the welfare state. So they don't see it's complementary as in Canada and Britain. It's striking, the difference.
Okay, but it works well, and it works well. But you are also a very small community. I mean, you're how many are you in Finland?
5.5 million.
See the difference?
Yeah.
So that's really a big problem. I mean, a big difference, right?
And we also have a few rich people, They are famous anyway, so they don't have to compete in providing millions for charity. Yeah, we do have, they pay a lot of taxes, so that's how they. Yeah. And that's also one essential difference, because they feel they already pay so much tax, they don't want to provide that for charity. It's over generalizing, but some truth in it. But to your original question, I haven't seen any professional who wouldn't think that you need sports. If you have a mental disorder, you need to increase physical exercise. It's important, essential.
Okay. Other questions? If not, we can start also with the Italian webinar and see the differences also in this exchange. I don't know, Uti, if you know about all our initiatives, our projects, because in over the past 2 years, we, as the European Culture and Sport Organization, which collaborates with Francesca Cirulli, Stefania Cerino, Marta Borgi, Barbara Collacchi, and other people here, we presented an Erasmus and won an Erasmus Plus project called the Sphere. Also, the Finnish, the Tampere Federation, the Sports Federation of Tampere was involved in the project as partner, and it aimed to define specific guidelines and a protocol to identify the best physical exercise for different psychiatric disorders. Mm-hmm. The project ended. We developed these guidelines, 19 guidelines, then disseminated at European level and at partner level, of course. And this project was followed by the ongoing project, and this webinar is included in this project called EASMH, that is European Alliance for Sport and Mental Health. And our main objective is to introduce physical exercise as a prevention and rehabilitation tool, and to create an European network able to promote these objectives. And so also this is why you're here today, and because with these webinars we're trying to understand the different the functioning of the different mental health systems in the partner countries. And so Jonathan Garside from Everton in the community arranged a webinar about the British mental health system. Some days ago we had a webinar with Romanian about the Romanian mental health system. Since in EASM now the partnership is composed of the University of Constanța from Romania, then of course ECOS as coordinator. Then we have Gaia Samponia and Andrea Fiorillo from the University of Campania, the Department of Psychiatry. And then we have the European Platform for Sport Innovation that today cannot attend the meeting. Everton in the community from the UK. And now we're involved in the European Psychiatric Association. We're finalizing the involvement in the consortium. And so these are the last meetings. I don't know if we would be able to organize another meeting, I think at the beginning of 2022, because the project will last till the end of December 2023. And so the last webinar will be about the Belgian functioning. And so I don't know if we'll be able, EPSI, the Belgian partner, will be able to organize the meeting by the end of this year, probably at the beginning of 2022. Anyway, I'm sharing some information in the chat in this group. So if you're interested in the project, the website is let's say under construction. But we defined an expression of interest for all people interested in joining the network, the EASM network. So if you have some colleagues or all people interested, sports technicians, all the people interested in the objectives, you can forward the link, the expression of interest to them, and they will be updated about all the project activities. Because over the next months, now the University of Campania is creating some training modules for the sports technicians, and so the sports technicians will be then trained about to manage psychiatric patients. And so there will be a specific training. All the materials will be uploaded on the project website and will be free for the people interested. Also the training will be free for all people interested in acquiring specific skills. And so you can forward all this information to your contacts if you're willing.
I already added to the chat 2 names that I know they would be interested.
Okay.
Gaia has worked with this Ice Hearts program for a long time, and several other preventive and especially sports interested in that. And then Virpi-Liisa is interested in economics, but she also was specifically interested in this cost effectiveness of increasing sports as a tool for mental health. So I think they would be good additions to your network.
Good. So I'm sharing the link in this chat, and then I have your email contact. I can also send it by. This is the home page, and in the home page there are 2 buttons, and the button on the right is for the expression of interest. It's a simple Google form. We're just creating a database at this stage, so we're collecting all the contacts.
Yeah. Okay, I will send this link to the people I mentioned, and
okay.
Thank you for your interest. Feel free to contact me if you're interested in this mental health strategy.
Okay, you can register on the expression of interest with the expression of interest anyway, so you'll be in touch.
Thank you. Good luck with your project.
Thanks. Now there will be the Italian webinar about the function. If you're interested and you're free, you can attend the meeting. If not, thanks again and see you.
Yeah, it's almost 4 p.m. in Finland, so I need to go.
Okay.
Thank you. Anyways.
Thanks.
Bye.
Bye.
Thank you. Bye.
Okay, so now Stefania, Francesca.
Andiamo avanti, no? Allora, now we go on, and I think it's been very interesting to hear, you know, the Finland situation from the point of view of a psychiatrist. I think it's been very interesting, and it shows us how you know, as you change the system, things can change dramatically, of course. So in Italy, we have a very different system, and Stefania Cerino and Gaia Sampoia will show you a little bit of how it works. And in Italy, it's different because we really what we are trying to do is to create a stronger link. And of course, the funding is also another very important aspect for building a real alliance between mental health and sport. In Italy, we don't have, I mean, the national health system is not so rich, clearly not as much as in Finland. And so it's very difficult for the public health system to finance also this type of activities. So we really, what we are trying to do, also thanks to this EASMH project, is to first of all try to derive as much as possible evidence that tells us that sport is crucial for rehabilitation, and at that point force in a way the system to incorporate or to create very strong links between and very also methodologically correct links between sport and mental health. I will leave now the floor to Stefania. I think you start now, Stefania. And so what Stefania will do is give you a picture, a little bit, a historical picture of how our national health system, which from a psychiatric point of view is very much developed, is very advanced compared to the rest of the world, I would say, but still it's not perfect. So I think this will come out from Stefania's picture. And then Gaia will go more in detail. Stefania.
Thank you very much. As Francesca told, I give you a little vision of the previous situation of mental health in Italy, so to best go deeper into the actually functioning of the services. So I'll try to share. Yes. Do you?
We don't see your slides, Stefania.
Oh, okay. So just a moment. Okay. Now you see? No.
Maybe, I don't know, Tommy, should you, and okay, now we can see them.
Okay.
Yes.
Can I start? Yes, you see everything? You see the slides?
Yes, we do.
Yes.
Okay, thanks. So I speak a little about the evolution of a psychiatric assistant in Italy. So the law of references is the Italian National Health Services. Is a law of 1978, and in this law they promotes the inclusion of psychiatric services among generally sanitary services, and this was a very important starting point for all the reorganization of all the mental health services. We have to say that in Italy, mental health services are free on national health services. The other law that I think everyone knows very well is the law Basaglia, the law number 180 about voluntary and compulsory health assessment treatment. After Gaia Zampogna will speak very well about the organization of the services under this law, but what is important is their key points, especially the closure of all public psychiatric hospital that was completed in 1999, except for the forensic ones that were closed in 2015. The creation of psychiatric wards in general hospitals, and the creation of local department of mental health that after Gaia will speak about. Of course, before this law, the situation of psychiatric care was very, very different because we know that in all Europe, the first psychiatric hospitalization began between 15th and 60s, when many countries established their house of corrections. The Panopticon from Jeremy Bentham is the architectural model of this type of house of correction, and what was particularly interesting was that these are not houses just for mental illness, but for criminals, for vagrants, for poor, and so on, because the mentally ill was in general considered as a degenerate. And in these houses, all the treatment, if we can say this, was physical restriction and punishment. The psychiatrists as we think it now is born in 18th century. The first psychiatrist who took to a humanitarian approach was Philippe Pinel, and the patient began to have a moral treatment, so to release them from their chains. In this time, the med is recognized as a sick, and this handling became a sanitary one, not just a punishing one. In that period began to be built some psychiatric hospitals in all Europe. Also, of course, in Italy, this is the psychiatric hospital of Naples, Hospital Leonardo Bianchi. Also, at the same period, began to appear in Italy the forensic psychiatric hospitals, very special structure. The first one was near Naples in Aversa, many years ago. And the characteristic of this structure is that the director is a psychiatrist, but the staff is from prison. We have in Italy 6 psychiatric forensic hospitals. They ran it until the 2015, were finally closed because their organization was not from the mental health service, but from the ministries of justice. There is before the law of Basaglia, there was in Italy we have been another important law in about mental health. The first one was in 1904, the Giolitti law. In those years in Italy, we have about 54,000 people interned in asylums. The hospitalization was compulsory and laid down by judicial measure, and people were permanently hospitalized must be registered in criminal records. It was created in this period a link between madness, criminality, and social exclusion. And what is really important is that law remained unchanged until 1968. In 1968, just some 10 years before the Basaglia law, we had the Mariotti law with some important changements. On medical request, compulsory hospitalization can be converted in voluntary one. It began the activity of territorial psychiatrists, psychiatry, where mental health centers are established to support psychiatric hospital activities in every region, in every territorial situation. What is really important is the abolition of compulsory notation in criminal record. Then we have the Basaglia law. Basaglia, I think, is the one, the most probably famous Italian psychiatrist in the world. He also was the director of the Gorizia and then the Trieste hospital. And with his idea in this work, he began to the institutionalization, from which in 1978 resulted the law named Basaglia. The central point of this law is the closure of all public psychiatric hospitals that in Italy was completed in 1999, the creation of psychiatric wards in general hospitals, the regulation of compulsory hospitalization, the creation of local department of mental health, and the community-based residential care facilities. This is a general scheme of the actual organization of the psychiatric assistance in Italy, but about this will be Gaia Zampogna that will speak after me. Just some words about the forensic psychiatric hospital that, as I said, on this hospital, Basaglia law had no effects, and we have to attend 37 years after the Basaglia law to have the closure of the forensic psychiatric hospital and then transformation in particular structures, regional structures named RAMS. In Italy, these RAMS are now about 30 with 500, 600 beds, and the patient staying is established by a judge. This final closure completed, from my point of view, the law, the Basaglia law. And just to finish, some data about the year 2019, about the number of the patient assisted by mental health service, the patient that had a first contact, the benefit of territorial service, the average time of hospitalization in regional structures is very, very high, as you can see, the number of compulsory treatment, and the amount of the total gross for the antipsychotic drugs, which is data very important for us, because our project with the comprehending the physical activity, the sport and psychiatric rehabilitation as the aims also to reduce the use of pharmacological psychiatric drugs. And with this, I can finish my my notes, and I think that Gaia can give you all the notice about the function of the mental health service. Okay.
Okay. Thank you very much, Stefania. Good afternoon to all. It's my pleasure to be here this afternoon and having the opportunity to explain very briefly and also in a very simple manner the type of organization of mental health services in Italy. Now I'm going to share my screen. I hope that you are able to see the slides. And as Stefania told us, the mental health system in Italy is organized as I have reported in this picture, because here you can see that, first of all, the mental health system is a community-based mental health system. And as Stefania pointed out, this was a very huge achievement by Italy as a state, because thanks to Franco Basaglia, we have completely closed the asylums, and we have switched our the type of care that we provide to our patients from an asylum-based model to a community-based model. And in this community-based model, the mental health department represents the core part of this organization. And then we have the acute inpatient facilities and the mental health center, and other types of facilities that are active on a community base. And now I will briefly describe to you the function of each of these parts of our mental health system, because I know that that it is a little bit different from the other countries in Europe. And first of all, the Department of Mental Health is the health organization responsible for specialistic mental health care in the community. And it is important to know that this part of the organization system was defined by this law called Progetto Obiettivo Tutela Salute Mentale 1998-2000, because this was a subsequent law that was approved in Italy following the 180 law, that is the so-called Basaglia law. And as also Stefania already pointed out, it is so important to remember for us Franco Basaglia, because maybe you know that his work has been translated in several languages worldwide, and also we are very proud of his activity, also because he conceived for the first time a new model of care for patients with mental disorders. And we are also proud to say that the model conceived by Franco Basaglia became a sort of model also for other mental health systems worldwide. So this is the reason why we are so proud, and for us it's so important to remember his work. And the Department of Mental Health is, I would say, a sort of organizational structure, because its role are dedicated to planning, to organizing, and to manage all the practicalities and all the activities that will be effectively provided to patients in the routine care. For example, there is a director of the Department of Mental Health that is always a medical doctor, and it is generally a psychiatrist, but of course his or her role in his capacity as a director is to decide how to allocate, for example, funding, and how to organize the activity of the department as a whole. And another very important element is that the Department of Mental Health provides these interventions through these different units that now I will briefly describe to you. But it is very important that the persons that can access to the Department of Mental Health are defined according to the catchment area in which the Department of Mental Health is located. And so this is the reason why we described our mental health system as a community-based one. And then we have the community mental health centers, which are the core of this community-based system. Why these are the core? These are the core because the community mental health centers coordinate all the activities that will be provided to the patients. In particular, they manage therapeutic and also rehabilitation activities that will be delivered in daily care units or in residential facilities. And furthermore, the community mental health centers are active every day, and as you can see here, in most cases they are active for all day long, night and day, or also just during the daytime, according to the level of staff and according to the level of funding that the specific Department of Mental Health has allocated to that the community mental health centers. And then it is very important to know that in the community mental health centers, which are the professionals that we will be able to find them. And here I decided to have this figure just to explain you that the equipe working in mental health centers is a multi-professional equipe in which there are, of course, medical doctors, there are psychiatrists, but we have also psychologists, we have social workers, we have professional nurses, but we have rehabilitation therapist. And this is a very important and specific professional figure that I would say it is a sort of specificity, a sort of a unique professional worker that we have just in Italy, because they are people that have obtained a degree in the area of mental health, and they have received a specific training on how to provide patients with a rehabilitation intervention. And so why it is so important? Because of course here also against the background of the EASMH project, in which we are aiming to improve rehabilitation intervention based on sport, of course it is essential also to strengthen the collaboration with all these professional figures, and in particular with rehabilitation therapists, because they must be aware of the role of sport for improving recovery in people with mental disorders. And then we have the acute inpatient care, and one of the main, one of the biggest achievements obtained with the Law 180 was, as I already told you, the closure of asylums, and because asylums, as Stefania told earlier, were something where the people were put in, and in many cases there was no possibility to be discharged. While now we know that patients with severe mental disorder can be, for patients with severe can be useful to have an hospitalization, and so now we have these acute inpatient units that are allocated in the general hospitals, because psychiatric ward is one of the wards of the hospital, like gastroenterology or cardiology. So it is a way to reduce the distance between psychiatry and all the other branches of medicine. And another very important thing is that now in our inpatient ward we have a maximum of 15 beds. And why is it important? Because again, during the era of asylums, these were huge hospitals with hundreds and hundreds of patients that were allocated in, and so it is now very important instead that we know that these wards must be with a very limited number of beds, also because for us hospital admission should be one of the opportunity to treat patients, but it is not the main way to provide care to our patients. And of course, admission can be on a voluntary basis or on a compulsory basis. And then we have the day centers that are generally open, as you can see here, 8 hours per day from Monday to Saturday, and usually accommodate not more than 20 patients. This is because in the day centers, mental health professionals mainly aims to promote rehabilitation activities, and also they lead, for example, workshops or any other kind of practical activities that can involve all the participants. So it is easier to manage a small group of people. It would not be possible to have, let's say, 100 or 200 people in the same center for doing this activity. And so usually these centers are accessed by subacute patients, and furthermore, for each patient it is possible to develop a personalized plan for rehabilitation, in order to evaluate the achievement of specific rehabilitative objectives and also to implement the activity of the internet with a specific patient day by day. And then we have also community residential facilities, which represents non-hospital setting, but community-based facilities that can provide overnight care for patients. And patients that are located in these facilities usually are in a stable condition of their mental health problems and require probably a high-intensity rehabilitation intervention. We can see here, we can classify these facilities according to the number of beds in high, medium, and low intensity facilities, but also on high, medium, and low intensity facilities according to the level of autonomy of the patients, and also reflecting the complexity of the type of rehabilitation intervention that we would like to provide to the patient. And I guess that now I very quickly arrived to my conclusion, because I decided to show you this figure that is quite a very famous, I would say, figure, because this is the sort of schema of the organization of our mental health system based on the model of Trieste, and in which all the elements that I have tried to describe to you are here reported, because we have the SPDC, which is the acute inpatient ward, and then we have the center for mental health, that is the place in which all the rehabilitation activities can be provided, and then we have the rehabilitation facilities. But I really like this figure, because it means a lot to me, because it very easily describe the fact that all these parts of our mental health system are interconnected, and at the center of this complex network we have put the patients, and so every kind of activities that we decide to provide to our patients is selected on the base of the specific needs of the patients. And so we are here just to accommodate our type of intervention provided to them according to his or her needs. And so I guess that this is a very important issue that we always must consider. And I guess that also this is one of the main strengths of our mental health system. And although, as Stefania told, and as also Francesca told, probably in Italy we don't have so much funding, public funding for our mental health system. On the other side, we know that the system itself it is very good, and so we are here trying to implement and improve as much as we can the type of activities that we are able to provide to our patients. And so I would like to thank you again for this opportunity, and if you have any questions, please don't hesitate to tell me. Thank you.
Thanks, Daria and Stefania, for your presentations. Are there any questions? Do we have make a comparison on the expenditure of for the mental health in Italy this year? Are there numbers to make a comparison with the 100 millions of euros spent in Finland to tackle also the pandemic in Italy? Have been published?
I would say that probably these are, of course, available somewhere. Now, I am not really aware of how much was the funding for mental health. For sure, it was not very high, because I remember that at a certain point, someone says that from the global budget for health, just 5% was dedicated to mental health. So, of course, we need to know which was the total amount, but in any case, 5% is a very small percentage. I don't know if Stefania or Francesca is aware specifically. But,
No, I don't
It's a
know,
good
but
question.
I don't think so, because generally the budget for mental health is very, very strict. So I don't think they give more fund in this period. I think no. But I am not sure.
2%, but I don't know. It's actually 2%, Gaia.
5 was
The
too much.
total spend, you know, of the total health, of the total spending for health. But I can't find the numbers. But it's gonna be interesting actually to look at this.
I found, for example, in 2019 it was the 3.5%, and
3.5.
3.5 in 2019.
It became worse.
The threshold should be 5% at least. I'm reading that is the last in Europe.
But I don't have the absolute number.
Yes, okay. Well, if there are no questions, we can close this session of webinars. Thanks everybody for your participation. And Tommy, just one request: if you can send together with the recording also